Hello everyone, myself Dr. Parth Goswami, and today I'm going to teach you a very important topic from hematology, that is the disseminated intravascular coagulation, formerly known by the name DIC. So the name itself suggests, within our circulation there is a formation of clot, microclots. So first the definition, what is DIC? It is a widespread thrombohemorrhagic disorder. See, it is not only the clotting disorder. There is not only clot formation, but as a consequence is bleeding will also occur. Why bleeding occur, that we will see later on in the slide. So it is a condition where the clot will form and bleeding will also occur. So it is a thrombohemorrhagic disorder. So it is very dangerous condition and it put a patient at a risk for the death as well. So, it is a secondary complication to a variety of disorder. It is a complication. It is not itself a disease. It is a complication to a different disorders. The common triggers are septicemia, that is the infection of blood, bacteria in the blood, then major trauma, obstetric complication, and the cancers, particularly promyelocytic leukemia. So these are the triggers. So DIC is a complication to widespread of disorders. So let's discuss which are these disorders that puts a patient at a risk for development of DIC. So what is the etiology? First is an infection. If the patient is having gram-negative bacterial sepsis within the blood, meningococcus infection, fungal infection, viral infection, widespread malaria in the body, then it can be a predisposing factor for the DIC development. Snake bite will also lead to DIC, vasculitis, vessel inflammation, also responsible for the DIC. Obstetric complication, so obstetric complication like that of retained dead fetus, septic abortion, amniotic fluid embolism, preeclampsia, that is a pregnancy induced hypertension condition, right? So in all that condition, DIC can develop. Two particular neoplasm associated with DIC. One is CA pancreas and another one is promyelocytic leukemia, right? This is the one of the type of acute myeloid leukemia, formerly known by the name M3. So in these conditions, DIC can develop. Another conditions are like that of massive tissue injury, which will lead to thromboplastin release, right? It will activate an extrinsic pathway of coagulation. So the etiology for that is burn, trauma, fat embolism, surgery, in which massive tissue injury can occur. Vascular disorder like that of aneurysm, dilated blood vessels, also put a patient at a risk for DIC development. And transfusion reaction. If the wrong blood is transfused, you know, DIC can occur. Now, before I explain the pathophysiology of DIC, it is very important to understand the normal hemostasis in our body. Then and then DIC can be understandable. So first let's discuss the normal hemostasis in body. How in our body the bleeding is stopped and what happened in our body after the endothelial injury. So, the normal hemostasis is maintained by a blood vessel, primary hemostatic plug, that is by platelet, coagulation system, and fibrinolytic system. These together will maintain our normal hemostasis. For example, look here, this is the blood vessel which is lined by an endothelium. Now, if there is an injury in the blood vessel, if endothelial is injured, then first platelet will come to form a hemostatic plugs to stop the bleeding. That is known by the name primary hemostatic plug. But that plug, that clot is not strong enough to stop the bleeding. So secondary hemostatic plug is formed by activation of coagulation system, which ultimately lead to fibrin formation. And this fibrin and platelet together will form a secondary hemostatic plug, which can stop the bleeding. And once this endothelium is repaired, once the function of this hemostatic plug is over, it will be removed by fibrinolytic system, particularly plasminogen activator. Plasmin will remove it. So this is called the normal hemostasis in blood vessel. Now let's see how the platelet and coagulation system form plug. So whenever the endothelium is injured in this intima, if the endothelium is injured, the first platelet will come to form the plug. So how they will form the plug? So because of endothelial injury, the subendothelial collagen is exposed. This subendothelial area that contain the extracellular matrix proteins like that of collagen, proteoglycans, fibronectin, other adhesive glycoproteins. So all that will be exposed to which a platelet will bind with the 1b 1x receptor, and von Willebrand factor will help in this adhesion. So via 1b receptor, platelet will bind to this exposed subendothelial collagen, that is known as a platelet adhesion. And after attachment, from the granule, ADP, fibrinogen like that of substance is released, which will attract more and more platelet. via 2B and 3A receptor, more and more platelet will aggregate together to form a primary hemostatic plug. And fibrinogen ADP will act as an agonist for platelet aggregation. Via 2B 3A receptor, they will aggregate together. So, that is known as a primary hemostatic plug formed by the platelet, and that's why they are. I'm remembering in that way that they are the primary commando in our body, right? So first they will stop the bleeding. Now, this particular hemostatic plug is not strong enough. We need a strong hemostatic plug for stoppage of the bleeding, and that strong hemostatic plug will be formed by subsequent activation of coagulation system, which will ultimately culminate to form a fibrin. So they will form a secondary hemostatic plug which is very strong. So they are like that of specialized commando to carry out certain mission, right? So they will stop the bleeding by forming a strong hemostatic plug. So see, in this way coagulation system is activated. We have two pathways for, remember, intrinsic pathway and extrinsic pathway. Extrinsic pathway, activated by tissue damage, by release of tissue factor number 3. Along with factor number 7, it will ultimately activate a factor number 10. A means activated. So this is the common pathway, that includes factor 10 activation. If we talk about the intrinsic pathway, then first number 12 is activated, then number 11, then 9, then 8, and ultimately 10. So the 10 is involved in a common coagulation system activation, common pathway of coagulation system. And once the factor 10 is activated, along with factor 5 and calcium, prothrombin, that is factor number 2, will activated into thrombin. And this thrombin ultimately will convert a fibrinogen to fibrin. So fibrin, this is the factor number 1. The fibrinogen will convert into fibrin. So this is the whole, this whole coagulation system is just to activate a fibrin so that they can form a strong secondary hemostatic plug. And once the function of this fibrin monomer is over, they will be removed by fibrinolysis. And the fibrinolysis is mainly carried out by plasmin, which is converted from plasminogen with the help of plasminogen activators. All right. And whenever this lies, whenever fibrin is lies, it is known by the name fibrin degradation product, which can be detected in a blood as an indicator of coagulation system activation. All right. So now let's talk about the pathogenesis and pathophysiology of DIC. Now you can easily understand what will happen in the disseminated intravascular coagulation. So basically there are two major events that initiate a thrombosis process in this particular condition. Because of tissue injury and infection, there will be release of procoagulate substance, particularly tissue factor, into the circulation. That is a factor number 3. And we all know that what factor number 3 will do. It will activate an extrinsic pathway, so ultimately fibrin will form. So in this way, coagulation system is activated and clot can form. Second important major event is widespread endothelial injury. And we know that because of endothelial injury, subendothelial matrix is exposed, so they will form more and more clot because of exposure of subendothelial collagen. So this is the two major event, right, in a pathogenesis. And because of that, clot will form. So what will happen after the clot formation? Here there is a consumptive coagulopathy. See, this word consumptive is very important because once the coagulation system is activated, when the clot is formed, once the fibrin thrombi is formed, during that process, they will consume the clotting factors and the platelet and the fibrin. So they will consume all the clotting factors and the platelet. That's why it is known as a consumptive coagulopathy. So this is the microthrombi in a circulation. Because of activation of coagulation system, the microthrombi will form in a circulation and it will consume the RBC, platelet, and the coagulation factor. So you can easily understand that what will happen because of that. In a circulation, your coagulation factor will be decreased in number, your platelet will be decreased, and because of that, patient can have a more chance of bleeding because these primary and secondary commandos are inactivated because they are less in number. So it will puts you at a risk for the bleeding. So here the clot will form as well as bleeding will occur because of secondary fibrinolysis, because this clot need to be removed from body. So the fibrinolysis will occur, and ultimately this coagulation factor and platelet will decrease in number. Because of fibrinolysis, fibrin degradation product will also form. All right. And because of this decrease in a coagulation factor, the prothrombin and activated partial thromboplastin time is prolonged because it will take a more time for the activation of this pathway, right? If your coagulation factor is decreasing number, and because of decrease in a platelet that is known by the name thrombocytopenia, the bleeding time is prolonged. Now, what is the role of interleukin 6 and tumor necrosis factor alpha, like that of inflammatory mediator in a DIC? So, in an infection, particularly sepsis, because of tissue injury and by endothelial injury, these inflammatory cytokines are released, particularly IL-1, 6, tumor necrosis factor alpha, and tumor necrosis factor. So, because of release of these inflammatory mediators, they will express a tissue factor in our body, and they will activate plasminogen activator inhibitor. See, this is very important. Because of expression of tissue factor, the extrinsic pathway of coagulation is activated. And because of activation of inhibitors of plasminogen activator, fibrinolysis will not occur. So there is an impairment of fibrinolysis and widespread thrombi will be there in our body. So what is the consequences of thrombi formation? If the microclot is formed, multiple microclot form within the circulation, then what will happen? What will happen because of widespread deposition of fibrin thrombi in a circulation? And that's why it is known by the name disseminated intravascular coagulation, because we have a widespread clot in our body, right? So because of that, what will happen? See, um, whatever area it affect, if it affect the coronary artery, then the portion, then blood supply of that particular portion is affected. See, this clot will lead to infarction, because if they occlude the vessel, then blood supply will not occur to the affected organ. And so because of that, there is a ischemic coagulative necrosis, which is known by the name infarction. So due to ischemia, as the clot occlude the microcirculation, because of ischemia, there would be necrosis. So multi-organ failure can occur because of infarction. So widespread thrombi first lead to infarction in the organs. And once the fibrinolytic system is activated, it will lead to lysis of clot. So because of that, there will be hemolytic anemia, because the RBC is also trapped in a clot, so it will fragment it. So it will lead to development of fragmented RBC, hemolytic anemia, where the RBCs are broken down early. And RBC once fragmented, they appear as a cystocyte in peripheral blood smear. See, this is the diagram. This is the peripheral blood picture of this hemolytic anemia. See, these are the cystocytes. They could be triangular shape, they could be helmet shape, any shape, but they are not round. They are fragmented. The spicules can be seen over the RBC surface. So it suggests that it is fragmented. So cystocytes can be seen. This blue color are the polychromatic RBC, which is due to increased reticulocytes secondary to hemolytic anemia. So this is the microangiopathic hemolytic anemia, which can occur because of thrombi formation. So because of widespread thrombi formation, there will be infarction, ischemic necrosis, and microangiopathic hemolytic anemia, which is very dangerous. So by hemorrhagic diathesis, now it's clear. The hemorrhagic diathesis is because of consumption of coagulation factor and consumption of platelet, and because of activation of fibrinolytic system. So because of that, patient will have a hemorrhage, because your platelets and coagulation factor can't stop bleeding now anymore, because they are consumed in a clot. And as the platelet is decreased, platelet are decreased because it is consumed by microclot. So because of that, thrombocytopenia, the patient have a high chance of subcutaneous bleeding. Patient could have a bleeding within the skin or in a mucous membrane. So this is a very large bleeding, chymosis, bruise. Petechial bleeding can occur, right? So skin and mucosal bleeding is seen. See, at the nutshell, this is the main pathophysiology of DIC. The whole lecture can be concise in this one slide. This is very important diagram to understand the pathophysiology of DIC. See, we have a variety of etiology like that of tissue injury or sepsis. Sepsis means, bacteria within the blood, and tissue injury could occur because of massive trauma, burn, surgery, or obstetric complication. So because of these widespread etiology, these two broad spectrum group of etiology, tissue thromboplastin is released, which is factor number 3. It will activate extrinsic coagulation pathway, so there will be coagulation in a circulation. And because of endothelial injury by any cause, like that of burns, glomerulonephritis, hemolytic uremic syndrome, aneurysm, atherosclerosis, any cause, if endothelial injury occurred, then platelet will aggregate, and subsequently intrinsic coagulation pathways are activated to form a coagulation in a circulation, because we know that once endothelial injury occurred, the platelet and coagulation system are activated. Now the microclots are formed within the circulation, and this clot can occlude a certain organs. So because of that, there could be infarction, ischemic coagulative necrosis. So there could be infarction because of microvascular occlusion. And once the fibrinolytic system is activated, microangiopathic hemolytic anemia will occur because the RBCs will also break down. All right. So, because of fibrinolysis, fibrin degradation products are released and the patient have a bleeding. The clotting factor and platelet are also consumed, so also there is a chance of bleeding. So here, because of two reason bleeding will occur, that is because of consumption of coagulation factor and platelet within the clot, and because of fibrinolysis. So here, the clot formation as well as bleeding both will occur, and that's why this particular condition is very difficult to treat because at one side you have a clot formation, and on another side you have a bleeding as well. So which are the laboratory findings in DIC? Now you can easily understand the laboratory finding. If you do the peripheral blood smear, then cystocytes are seen. Prothrombin time and activated partial thromboplastin time are increased. Prothrombin time reflect extrinsic pathway. Activated partial thromboplastin time reflect intrinsic pathway. So here, as the coagulation factor decrease, PT, APTT both will increase because it will take a time for a body to form a clot, right? So the PT and APTT is increase. Thrombin time also increase, then fibrinogen will decrease, and bleeding time is increased because of thrombocytopenia. Whenever the platelet are decreased, bleeding time is increased. That is BT test. So this is known as a screening test. If this screening test is abnormal, then it could be a DIC, and you need to do a confirmatory test for DIC detection, and that is a fibrin degradation product and D dimer. So what is fibrin degradation product and D dimer? So fibrinolytic system will degrade the fibrinogen as well as fibrin. So that is known by the name fibrin degradation product. But if specifically fibrin degradation product, we are estimating only fibrin degradation product, then it is a D dimer. So the difference is that D dimer is a degraded product of cross-link fibrin, while the FDP fibrin degradation product is a degradation product of cross-link fibrin as well as fibrinogen. So we can say that both are indicator of fibrinolysis. Both will be increase in disseminated intravascular coagulation, but more specific one is D dimer because it will more reflect the DIC, that is a fibrinolytic system activation. So FDP, fibrin degradation product, and D dimer will be increased. Both can be estimated by ELISA or agglutination based assay. Nowadays automated coagulometer are available which can easily detect the D dimer and fibrinogen by immunoturbidometric method. So it replaces the manual methods, right? So automated coagulation analyzer can estimate your D dimer and FDP, and if they are increased, this D dimer and FDP, if they are increased, it means that clotting in your body occurred. So it is indicator of DIC, right? So that was all about the disseminated intravascular coagulation. Now let's discuss 2 to 3 MCQ so that I can know that you have understand the lecture. So all the following are anticoagulant substance except antithrombin 3. Yes, it is anticoagulant substance. Protein S, yes, protein C and S will inhibit factor number 5, so they are anticoagulant. Nitric oxide, yes, it is also anticoagulant, but von Willebrand factor is not anticoagulant. In fact, it help in clot formation to the platelet. Second MCQ, very important. 53-year-old man has a medical intensive care unit for septic shock for the past few days. Now he has developed rectal bleeding, epistaxis, and bleeding. See, the patient was admitted for septic shock. Septicemia was present, but the bleeding was suddenly started. So clinician, immediately suspected DIC. Now, which of the following set of result of panel of screening test is the most consistent with diagnosis? So, which screening test will reflect that it is a DIC? Normal bleeding time, PTA, PTT, obviously not, because if it's normal, then it's not a bleeding disorder, right? Prolonged bleeding time, yes, can be seen because of thrombocytopenia. PTAPTT is prolonged, yes, because the coagulation factor is consumed by by clot. Thrombin time will increase and platelet count will reduce. So this is the right answer. This panel will indicate that patient could have DIC. Because of less platelet, reduced platelet count, bleeding time is increased. Because of coagulation factor consumption by clot, PT and APTT will be increased. So this is the right answer. A 25-year-old man in the 25th week of pregnancy has no fetal movement since 3 days. 4 weeks later, she still doesn't give the birth and suddenly developed dyspnea and cyanosis. Blood pressure was fall down. See, shock like condition arise. She has large ecchymosis over the entire body. The bleeding, skin bleeding is there. Large bruise is present. So patient have problem in a platelets. A stool sample is positive for occult blood. So bleeding, mucosal bleeding is also positive. Occult blood is positive in mucosal bleeding from intestinal bleeding. Lab study revealed the PT-APTT increase, platelet count decrease, and fibrinogen is decreased. FDP is detected. Very important. This is confirmatory test. Fibrin degradation product is detected. So clot is occurred, and the patient, have the bad obstetric history as well. Abortion history is present. See, patient has abortion history. So this is classically a case of DIC. So which is the most likely cause of her bleeding diathesis? So obviously, bleeding is because of consumption of coagulation factor, because the coagulation factor and platelet are consumed, so it will lead a bleeding. All right. See here written as platelet aggregation is defective, which is not a case. Platelet aggregation defect is known by the name Glanzmann thrombocythemia. Increased vascular fragility is not there. Reduced platelet production. The production is also not affected in DIC. All right. So the answer is consumption of coagulation factor. So that's all about the today's lecture on disseminated intravascular coagulation. These are the references for my today's lecture. All the books are good. You can choose any of the book, uh, which is easy for you to understand. So that was all about the disseminated intravascular coagulation. At the nutshell, don't forget that this is very lethal condition. Here the clot will form, microthrombi will form, and it will consume the coagulation factor and platelet. That's why they are reduced in number, and it will increase the PTA, and increase bleeding time. Fibrin degradation product is detected. D dimer is also increased, which is a specific test for confirmation of DIC, and this is a screening test. All right, and because of widespread thrombi, it can occlude the vessels, so particular organ can have infarction. That is the ischemia-induced coagulative necrosis. As the blood supply will not reach, there will be coagulative necrosis, which is known by the name infarction. And as a fibrinolytic system is activated, microangiopathic hemolytic anemia will occur. So fragmented RBC can be seen in peripheral blood smear. All right, so that was a pathophysiology, right? Microangiopathic hemolytic anemia, necrosis, and bleeding. So that's all about today's lecture. I hope you have enjoyed this short tutorial. Thank you very much. And I will be right back with a new video. Till then, take care and bye bye. Thank you.